I'm Lillian Butler-Hale. I am our Director of Outreach and Engagement at Open Sky, and I have the honor of introducing our first panel. You've probably heard someone say that health is wealth, and I am inclined to agree. Having a healthy, thriving population is not only good for Nebraska's well-being, but investments in health infrastructure have some of the strongest returns on investment. Please welcome to the stage our moderator, a passionate advocate for closing the gaps in health outcomes, and a standout member of the Legislature's freshman class, the Honorable Senator Ashlei Spivey. And I'll also take a chance to introduce our panelists to you. We have the Honorable James Michael Bowers, Executive Director of NAMI, Nebraska. James, if you want to pop up here. We have Dr. Ali Khan, who is the Dean of the College of Public Health at UNMC. And we also have Dr. Kiley Petersmith, Assistant Professor at Nebraska Methodist College. Thank you all for being here, and we'll get started.
Well, good morning. I'm glad to see y'all. So many smiling faces that I know and some new folks out here. So I'm really excited to jump into this panel to talk about health and health equity and what does that look like at the state level, especially with folks that are really on the ground and help to influence our policies. And so I am Senator Ashlei Spivey. I represent District 13 in Northeast and Northwest Omaha. Whoop, whoop, for anyone that's in my district or knows what it is. And have spent a lot of my career working in public health, which specifically maternal and child health, and then how does that relate to economic opportunity? And so I think today my goal is to really dive into how do we translate these things of on the ground work, direct service, and then what does that mean as we talk about policy priorities for our state? How do we allocate our budget? Because as you saw last session, we all have choices. We make a choice as a body to prioritize what we fund and what our budget looks like. I think it's really important to make sure that we're informed about the implications of that prioritization and what does it look like. And so I just want to take a moment for folks to just introduce yourselves a little bit more in depth. So if you can give maybe 45 seconds, a minute, just who you are and the work that you do, and we'll start here with James.
Well, thank you so much for having me. My name is James Michael Bowers. I am the Executive Director of NAMI, Nebraska. NAMI stands for the National Alliance on Mental Illness, so we run the state chapter here in Nebraska. We provide education, advocacy, and support for those impacted by mental illness and their families. In addition to that, I'm a member of the Lincoln City Council, where we've been dealing with some mental health and behavioral issues lately. And I also want to give a shout out to my mental health, behavioral health policy partner, Amanda McGill Johnson with Nebraska Cures in the back.
Thank you, James.
Good day. You can hear that. Good day, everyone. I'm Ali Khan. I've had the pleasure for the last decade of being Dean of the College of Public Health at your University of Nebraska. Our focus since I've gotten here has been how do we make Nebraska the healthiest state in the union with the best science and the best set of practitioners.
Fantastic. Good morning, everyone. Yeah. You passed the baton so quickly. It was good morning.
The senator said 45
seconds. Okay.
And I appreciate that because otherwise we'll have like the little person that tap dances and tells you to stop.
Okay, good morning. I'm Kiley Petersmith. I'm a nurse by trade and have background working with children with special needs in home health. I was a trauma critical care nurse for about 10 years and most recently have transitioned to the public health sector, doing community engagement at Nebraska Methodist College, overseeing the programming there, and now teaching in the doctoral public health policy track.
Thank you. Let's give our panelists a round of applause.
And you.
Yeah, of course, Mia. Yeah, of course. So let's kind of ground us in understanding the impacts on what we spend on health. And so health and healthcare are one of the largest portions of our state budget through our general fund spending, primarily through the state's Medicaid and CHIP programs. And so maybe Dr. Khan, if you want to start, and if any other panelists want to add to this, how would you describe the return on investment to our state for spending? When we talk about spending and prioritizing those programs, what is the return? Is it worth it? How does that actually help in terms of dollars?
Glad to, and thank you for that question, Senator. So it's about $3 billion a year of your state budget goes to Medicaid and long-term care service. And it's critical for the health of everybody within this state. It supports about 19 or 350,000 recipients here within the state.
Dr. Khan, can you lift your mic up a little bit? I just want to make sure folks can hear.
The 3 billion part, or the 350,000 people who really depend on Medicaid for their care here within our communities. So within the state, about 40% of maternal care is provided by Medicaid. And in rural communities, it's actually higher. It's about 50% of care is provided by Medicaid. And $30 million of your dollars go to support schools for special needs for these kids. If I get one more, another 45 seconds. If we look at more around metrics, so we do okay in terms of access, and I have the data for you. 90% of children report getting needed care always on time. 85% of adults report getting needed care always on time. Not so well on metrics. So only 80% of women receive a prenatal visit in the first trimester. Only 40% of children who are 2 years of age have actually received the full complement of vaccines here in the state, and only half of women between 50 and 74 have had a mammogram. So again, lots of work to do in terms of quality metrics for the $3 billion.
So then do you think, just to piggyback on that, and Dr. Petersmith, if you have ideas too, so what I heard you saying is that we're investing a lot of money, it's important, and then there is maybe some disconnect or dissonance around some of those metrics around well-being. Can you maybe speak to that, either one of you, if you have thoughts?
I can just extend it and turn it over to you. Yes, there's a great opportunity to improve the value from this investment within the state and improve the quality of care for these 350,000 people within the state.
Thank you.
Yeah, I can just speak from a nurse who has worked with a lot of children who have been on Medicaid, and that Medicaid helps prevent access points or touch points for practitioners. And we do a lot of work working with schools and libraries and places outside of the typical medical home, because we're able to then kind of supplement the resources that would be done in the medical home. So, typically a lead screening is recommended at a Medicaid visit for children at 12 months and 24 months. Lead screening is critical. Lead is a heavy metal. It's a neurotoxicant for children. It can cause developmental delays and speech and language delays. And it's so important that we have these touch points for our children so that we can provide prevention. We know that a lead test is $7 to implement, but if we invest those $7 for all 180,000 children that we have on Medicaid in the state of Nebraska, that's like around $1.2 million of that budget. But we then are potentially reducing $5.9 million in healthcare costs for those children every year, and up to $50.9 billion in economic productivity for those children. If we're able to prevent it early by having that access point and having that payment point, then we're able to save money.
So what I hear you saying is preventative care, and that investment is really important because we see then the benefit long term.
For sure. You could say the same thing about a vision exam for a child. It's like if you have that touch point, you check the vision. It's a simple test. That's a free test you can do. And you recognize that a child may need glasses, then you're keeping them in school. You're keeping them in school to learn, reducing their anxiety because they can now see the teacher and see the board that they're learning from. And you're also potentially reducing hospital or, primary care visits because they may no longer have headaches or dizziness when they're learning. And so I think we have to think holistically when we're thinking about the investment in healthcare dollars, and that what other things should we also be including in that bucket that might not always get included in that bucket.
And to stay along that theme, Dr. Petersmith, if you can maybe speak to what are some of the most pressing health concerns or that we're seeing across Nebraska? I know that you are kind of on the front lines with that acute care. And so in your opinion, what should we be knowing about because we are not necessarily practitioners in the same way?
Okay, that's probably the hardest question anybody has asked me. I think in order to do policy work well, we have to understand the incredibly complex context that we're living in, right? We have 60% of Americans that are living with at least one, if not multiple chronic diseases. We have attempts right now to degrade the value of public health and the trust in public health. We have an opioid epidemic. We have barriers in access to care. 1 in 5 children in our state are going to bed hungry every night. Thanks to the work that Dr. Khan has done, we know that there is a life expectancy gap in our state from one zip code to another of 18 years. So the average age of how long people are living is 18 years difference from one zip code to the other in our state. So I think that we can't really say that there's one or more most important or most pressing, especially when we're thinking about our most vulnerable, our children, our people who are living in lower socioeconomic statuses. All of those things that I mentioned are compounding. Where we live matters, and it's compounding. But I would say that, housing is another option that I didn't really mention, but we have a huge lack in affordable and safe housing. And that's a Maslow's hierarchy of basic needs. So if we don't know where we're sleeping at night, how can we think about our, what we're going to eat, or how we're going to pay our bills, or how we're going to go refill our medications, and just the toll that takes. So if I had to pick one of the most pressing issues, I would probably say that housing, just because it has such a complex dynamic on all of the other public health impacts.
You want me to tackle that from
just 1 second. So James, I'm going to get to you. If you could start thinking about some of the behavioral health stuff and what's coming up. So I have one more question before we kind of shift and talk about the impacts of behavioral health. But Dr. Khan, if you can maybe expound on that. And for the group that maybe is not in the public health space, can you kind of speak to social drivers of health and how we can think about those drivers as it relates to building strong policy and aligning that policy with our budget?
Absolutely. And let me actually identify 3 areas of high priority in the state that are amenable to good policy action right now. So let's start with infant and maternal health issues. For the last 5 years, we've had a slide in infant mortality in the state, and I believe it's going to be true when we see 2023 data. And the gap between white babies born in this state and black babies born in this state continues to increase. That is as an economic cost to us. So if you think about not all babies, so we have 25 to 2,600 premature births in this state every year. Not all babies obviously need ICU care, but if you need ICU care and you're premature, that's about $3,000 to $7,000 a day from the ICU care. And then if you move past the ICU care, many of these kids are also going to need care once they move into the school system. So that's that ongoing cost of these children that could have been prevented if you had said, let's make sure you have an early prenatal visit. Let's make sure you get risk stratified to see whether or not you need high-risk OB or not. And then all of a sudden you have kids born on time. Hello, right?
I would also add an access to doula care or midwifery.
Fair enough. As you very well know, Senator, all sorts of the components of making that happen. So I'll take that. The second thing is hypertension. So half of Nebraskans have hypertension. Probably less than 12% are actually adequately treated. The data is pretty clear, about $2,000 a year in savings for every person that you treat with hypertension. And the third one I'll do is obesity. So Nebraska is a little bit better than the rest of the union. 30% of Nebraskans are obese. That's scheduled to be 50% in 2030. So we are sort of marching along as the rest of the United States, and that doesn't even tackle the rest that are overweight. We have really good data at this point. If you look at either Medicare patients or private insurance patients, that you can save money using GLP-1 agonists. So if you're willing to invest in using these brand new drugs, you can actually save money long term. But there's all sorts of other things in that space that you can do. So for example, in this state, which still surprises me, pop is considered a food. And so it's untaxed. So forget about having taxes on sugar-sweetened beverages. I'd like to just start with considering pop not a food so that it gets regular taxes. Forget about extra taxes. So there's a lot of things that can happen in the policy space here. But again, cost savings in all of these three areas. Now, you can wrap all of these around issues around social determinants of health, which I am now carefully calling political determinants of health. I think we've gone from blaming people for their own health problems to essentially then blaming their community for their own health problems, instead of recognizing that it's policy that defines whether you have a job, whether you have education, whether the bus stops somewhere nearby, whether or not you have sidewalks. I think we just need to, whether you have a roof above your head, I think we need to decide these are policy decisions. These are not failings of an individual or failings of a community, right? And so I now call these political determinants of health. And this is where good policy has an opportunity to make a difference in people's lives and help make Nebraska the healthiest state in the union, where everybody has an opportunity to thrive.
Thank you. Y'all taking notes? Because we having a panel this morning, okay? All right. So a part of public health, and thank you both for that insight and like grounding us and what does that look like. There's been more attention to behavioral health and the needs around our community. And so, James, if you can maybe ground us in like, what does that look like? What are you seeing? And what is the current landscape in Nebraska around behavioral health support?
Yeah, absolutely. And I really appreciate what you said about it being a political determinant of health. That's something that I think will really stick with me. When I was prepping for this panel, of course, I wrote a bunch of facts and statistics out that we all know, right? We know that the pandemic really has brought a spotlight to mental health and substance use in our world. And in areas where there are different political determinants of health, those differences have been magnified and highlighted even more. We know that in Nebraska, there's varying levels of providers, right? And access is hard for folks to be able to go to, either because of payment, because of the lack of providers, or even understanding how to navigate this very, very complex system of mental health care, right? And so what we're seeing is providers continuing to graduate, but I think that we could really benefit from having a really innovative view of what does it mean to provide services to folks. Can that be done through peer support services? What are some of these things in our environmental world that we can do to be able to improve behavioral health outcomes in our community? And that's been really hard for some folks to think about because it requires looking at how we're doing things differently. And typically, sometimes when we look at policy, we look at how things have been done and the political reality of things, right? What can people get pushed through in their legislative bodies, or what can an executive branch do? And so it's really going to take some bold leadership to make some of these changes to improve behavioral health outcomes in our community. In addition to that, when those investments are not being made into behavioral health, other systems have to pick up the slack for that, right? Mm-hmm. When kids don't have access to their behavioral health needs, that makes it harder for the teachers and the social workers and the counselors in their schools. I spent the majority of my career in a school, right? And so if we were able to have a system that actually works for folks, we would be alleviating the pressure on all these systems that are under attack right now, like our education system. And so mental health really is not a niche clinical issue. It's really foundation to our resilience of a community and our productivity and family stability and being able to mitigate long-term costs. And the last thing that I'll say as I wrap up this ramble is we talk about how stigma is starting to fade away and starting to go away, but it still very much exists. The amount of policymakers that I interact with that say that I have the same experience, but then they're nervous to talk about it, is something that I think is really, really interesting. And so often we talk about getting people elected into these positions to be able to speak for their communities, but with mental health and substance use and behavioral health, that stigma still exists. And it makes it harder for people that have been caught up in the system to see themselves being able to make change, but also makes it harder for policymakers to be able to speak authentically when they're talking in the third person, when this really has a personal impact for the majority of policymakers in our nation.
Can I ask a follow-up to that? Because I think there's a lot of language or maybe misunderstanding, as you mentioned, around like behavioral health, mental health, and what does that look like? And you just gave us a charge to be creative in how we address it. When you talk about behavioral health or the access to, is that therapy? Is that like what does that look like when you talk about the landscape and the access to care points, and how then again we can translate that back to, okay, here's a type of policy example maybe that can help address or push some of the ideas that you have around creating stronger communities?
Absolutely. So I think one thing that, to be very, very frank on, is that there's so many providers out there that don't understand our continuum of care, right? Especially in the mental health world. And I'm speaking as a clinician myself, right? I'm a mental health therapist, social worker, on that. So the continuum of care of what it means to go from traditional outpatient to intensive outpatient to inpatient care is really confusing. And so many folks have not been educated on what it means to go through that continuum of care for our patients that we serve or the clients that we serve. And so I think being able to demystify that helps empower providers to be able to inform the folks that they're working with to create more realistic expectations. So often we'll see folks that will wind up at a hospital emergency room not being connected to care or being connected to an outpatient provider, but then having a crisis develop and then not being admitted because they're not an active threat to themselves or someone else, and not being able to understand why. And that creates even more friction and more distrust between clients and patients and providers in the mental health system. So being able to demystify that, I think, would be, for providers and also for the general public, I think would be really key in helping people understand where things are at, right? In addition to that, I think that if we are able to really, and this has been a topic with every policy that's come up, so this isn't anything new, but it's something that we should really continue to harp on, and that's being able to listen to people who are caught up in the systems themselves, right? Being able to be proactive and reach out to people and say, you've gone through this, you have been a victim of the failure of our behavioral health system. Where did we go wrong? And what would it take in order to make things better, right? So often people will say, well, we have public hearings, or we invite people to provide their feedback. But being really intentional about that is where you're going to find those golden solutions to be able to meet people where they're at. Now, those solutions are going to be really bold and really innovative and maybe hard for folks to have that vision or swallow, or where they're going to get the dollars out to make that happen. But that's where you're going to get the most authentic answers from, right? And so I think being really intentional about policy creation and reaching out to folks who have been in that experience, I think is really, really crucial into creating really good, sustainable solutions.
Yeah, I love that, to center the people that are most impacted, to curate and lead, which I think is really, really important. Through this process, right, like ideally, my approach is that you don't make policy in a vacuum. And as a state legislature, I still have to work with city officials, school boards, county level folks, right, to curate the solutions, because we're talking about system level change and what does that look like. And so there are some other elected officials in the audience that maybe represent their cities or counties, school boards. I see some folks from Omaha. Hey, booze. And so what does that look like in terms of how they can approach some of these really key health opportunities that you lifted up, and how they can prioritize at their level of government or influence? And maybe Dr. Petersmith, do you want to start with you, and we can work our way back down for folks that have ideas?
I would start with, we as Nebraskans have a strong sense of community, a strong sense of self-reliance and dependence on ourselves, and we have a really strong work ethic. So you can start by leveraging those assets, right? So I'm a daughter of a farmer, a granddaughter of a farmer, and I think about my fellow farmers across the state of Nebraska in these rural towns who are potentially losing their livelihoods because they can't afford to keep their farm. And in the same breath, we have, again, children who are going to bed hungry every night. We have food deserts across the state, and we have in our grocery stores ultra-processed foods that are not nutritional, and they're contributing to this chronic disease that we're seeing in adults. So how can you, as municipal leaders, leverage funds to keep the money in your community, keep the food in your community, put the food from those rural farmers? This is just a hypothetical thing that I wish I could see. So let's make it happen. But let's keep the food from our rural farmers on our grocery store shelves, and let's leverage that money to make that food affordable for the most vulnerable, our children and our low-income people who are living in our communities, and get rid of the junk that's sitting on our shelves that's contributing to disease. So I think that is keeping the power in your community. It's lifting your community voice and keeping the things that are most valuable and tangible for them. And it's keeping the money in your community, and how powerful we have seen recently in our media, how powerful the consumer dollar is. So how can we just be more innovative and creative and leverage that money?
And I like that ecosystem that you talked about, from like farm to table. What does that look like and how it all connects? And so really trying to build a stronger ecosystem.
Yeah, and it might be a little scary to put a big dump of dollars invest into rural farmers, but to then think about that ecosystem. And when you're investing money into healthcare, into the healthcare budget, all of your other budget line items are going to be impacted too. So you have to think more holistically there.
Dr. Khan, I see those wheels turning. What are you thinking?
So I have all sorts of ideas about payment and delivery policy options, but I'll hold on those for a bit. I want to take the broader question. And, when you started talking about this holistic approach, one of the things that many of us in this community have been advocating for is free school lunches, free meals, school meals for all kids. That would dramatically address our obesity problem and hunger problem. And it's not novel. There are already states that already do this. So we wouldn't even be novel by saying feed every kid. But I like the connection that you heard from Dr. Petersmith, which is back to our farmers. Let's take advantage of the fact that we are an agricultural state. I mean, how about some fresh fruits and vegetables that those kids then could get in these meals, which would make them healthier than some of the ultra-processed food. So it's a nice way to connect back our farmers back into our school higher education and taking care of hunger and obesity at the same time by feeding kids. Going back to your earlier question, Senator, so I crisscross the state all year long, given the nature that we're the College of Public Health for the whole state and not for Omaha. And there's an immense talent in the state. For those of you who live here every day, you probably do not appreciate you have some of the best healthcare in America right here in Nebraska, between multiple health systems, right? People would not understand how 2 million people, right? It's 2 million people, but the quality of your healthcare is actually excellent. And we have metrics from the accountable care organizations that verify that the quality of healthcare in this state is absolutely excellent. You have a great public health department, you have great local health departments, and people actually work well together. I have the pleasure of hosting a group called Align, which is essentially all the major health systems, all the insurers, all the state health departments, other partners. And we talk about, currently our current project is around infant and maternal mortality. Previously it had been around colorectal cancer screening. But there is no competition in this state about making Nebraskans healthier. People will come to the table and say, how can we work together and make it happen? So it is a wonderful environment for good policy to continue to make us healthier.
Thank you. One of the things that's been top of mind, so I'm on appropriations. And so I've been spending a lot of time like in the budgets, in the things I've been trying to balance while we were in session, watching what was happening at the federal level with the changes in legislation. And this is not a question, so I'm going a little off script. But I think, again, what happens at the federal level, then the state, to the county, to the city, to the school, like all of these things have ripples and impacts. And so from what you understand now about some of the changes to Medicaid, access to care, in your respectful areas of expertise and practice, what are the implications or things that we could be prepping for? I have been trying to research around, okay, if these reimbursement rates get cut, what is the state's responsibility now, right? Like, so I am trying to prepare myself to be knowledgeable and responsive when we are back in session as a member of appropriations. And so what are things that we need to know and understand about the changes in some of these key areas of public health that we need to start to research and be ready to respond to as Nebraska?
I this is kind of on my mind, and so I kind of want to, throw this out there. And it relates to what you're saying about kind of like all levels of government. And I agree, we have quality healthcare here, but for those who can access it, right? I think it's really hard for people, and it almost makes them less likely to speak up when they hear that we have such a great system, but then people in my neighborhood die 15 years sooner compared to people than in South Lincoln, right? When my mother can't get a surgery that's now impacting her about 15 years ago because we couldn't come up with $1,500, right? And so like we do have a good healthcare system, but I think remembering for those who can access it, right? And I think that that's something to like really keep on the frame of mind. I also agree that like the local boards of health are really underutilized when it comes to being able to get things done. I'm president of our board of health for Lincoln Lancaster County, and we have an excellent health department. They are the most dedicated people that I've ever met in my life. Pat Lopez is a saint, you know what I mean? Like guided us and protected us, as we went through the pandemic and as we, recovered from COVID. And so often when we talk about the political will to get things done, there is a disconnect in people's philosophy and in their actions, right? So often we'll hear from folks saying that like, well, we need to do something about our substance abuse issue because they don't want to have homeless people in their neighborhood. But then when it comes up to being able to put Oxford houses, these recovery homes in people's neighborhoods, there is lined up NIMBYism, not in my backyard people, who will fight against it. And then we have local elected officials who then will, in an effort to score political points on that, will then fight against the very thing that people are trying to prevent happening in their neighborhood, right? People don't want to have homelessness in their neighborhood. People don't want to have substance abuse in their neighborhood. But instead of trying to follow federal law, there will be often fights to just not have it all exist and to hide it away. And that's not a realistic solution. And so I think, it would be great to be able to rely on state government and our local elected leaders to then be able to figure out what is the lane for each level of government, right? And I think that those lines get really, really blurred. Local government, a lot of times, should not be, overseeing the programming of an outside entity, right? One of the Oxford houses that came in front of council before, they wanted to have the city be able to like audit their records that they had for the treatment that was being able to be provided. And that's not a city level responsibility. Now, when it comes to like an accreditation or a licensure on the state level, that would make more sense if that is, a policy decision that people want to go through. So I think it's really important being able to be clear about what is the line of government, and then being able to have elected officials that aren't willing just to score cheap political points, but instead take some bold efforts to say like, this is going to be hard, but this is what we all want as a community. And if we really want to have a healthy community, we do need to improve access. And some of these things that may be unpopular will get us to a healthier Nebraska.
Thank you. Dr. Khan?
So I want to start with the positive. So there's no doubt. I'm a public health clinician, right? So I'm like, what's wrong? How do we fix it? As opposed to, wow, there's a lot of good stuff that happens. So I'm going to start with the positive. So without a doubt, access is an issue. And even if you have access, we know there are not, for example, sufficient mental health providers within our communities. But we have great examples where the state has stepped up and said, we're going to do the right thing. For example, we expanded Medicaid. Last in the nation, but we expanded Medicaid.
We still did it.
We still got, we got there.
Yeah.
We got there. We expanded Medicaid, and kudos to the current governor. I mean, we extended care for moms who had given birth from 3 months post-birth to a year post-birth, right? Last in the nation, but we still got there. So, we do have the ability to do the right thing here in the state. So, and I feel that way about anything that we talk about today, that we have the talent in this state to say we can get this right. We have gotten it right, and we can improve access issues, and we can improve quality issues. I do want to make a quick jog about substance use. So, for example, in the legislature was a great bill around harm reduction, great data of what you can do with syringe exchange programs. And even though the decision was at a local level, if they wanted to do it or not, it couldn't get its way through the legislature. which was disappointing because the data is pretty clear. If you want to address substance use, you want to work on harm reduction, which includes an increase in HIV we're seeing in certain rural communities or micro communities within Nebraska, you're like, okay, how do we do harm reduction? So I think that's a good example with the lighthouses of where we do ourselves in to do the right thing. Now, as far as from the federal to the state, so since we are your University of Nebraska, on our website is a position paper on what the impacts of Medicaid cuts will be to their state. They will be profound in loss of health care for people, in less providers, and loss of tax revenue for the state. So there's profound effects for the state around Medicaid, all available on our website. So that's one piece of it. And rural critical access hospitals that are already stressed, yes, we're all grateful that there's $50 billion extra for rural health. That's not going to fix the problem of the cuts that we're going to see happen. And so if you live in rural Nebraska, you should be very worried about whether you're going to still have a hospital, to be very honest with you. The economics do not work for them the way they're currently structured. We have ideas on how to improve the economics, but they do not work for them how they're currently structured. But that's just from the health side. You can look at what's happening at the EPA side that's rolling back protections against mercury in the air, sulfur in the air, carbon dioxide in the air. Well, that's opportunities at the state level to say, you know what, we really don't want our citizens to be breathing in more mercury and sulfur and carbon dioxide, the soot and the PM and all the particles that come into combustion. So we don't care what the nation's doing at a state level. We are going to protect our citizens from this pollution that's getting into their bodies and causing all sorts of chronic diseases and cancer, right? So there is an opportunity at the state to mitigate some of these changes that are happening at the federal level. So those are in two places. I could go on and on about what's happening in higher education, but I'll stop there and stay in the health lane.
Thank you, Dr. Khan. Dr. Petersmith,
Yeah,
anything you'd like to add?
Yeah, most of what I was going to say is very similar in leveraging our assets. We, again, live in a state that has resources. We have a lot of wealth in our state. We also have great resources that at county health department levels, at colleges and universities. And some of the best work that I've been involved in has come from sitting around a table in the community and talking about the needs, and then bringing in all these different avenues, a private health insurance company, the state and local health departments, and the resources from colleges and universities to address, we're doing that with our lead screening program. We worked with the College of University of Nebraska, UNMC, and a couple other community colleges, as well as state and local health departments to address the school nursing shortage across the state. So we've got some cool, innovative things that can come from having a conversation about where our true needs are. And we have to get out of our silos, and we have to start talking to our neighbors in other cities and towns and other colleges and our nonprofits, and leverage all of our unique talents together.
Can I add something to that?
Yeah.
I agree with that. And I think that when it comes to talking to members, we have to be able to fund that also, right? Yeah. We have to be able to fund, organizations and the people power in order to get that done. Because if we don't fund that kind of work, then it's a good idea and people should do it. But that takes time, that takes capacity. And when we already have organizations like, schools or nonprofits that are already at the brim facing federal cuts and, dealing with traditional community issues, being able to fund that work to be able to do that community building is extremely important. One other thing that I want to say, and then I'll shut up, is counties and municipalities really are often the front line of behavioral health, right? When it comes to law enforcement, housing, with zoning, emergency response, public health. And so just like how behavioral health policy impacts all areas of policy, and we're starting to believe that as a society, so does funding, right? So when the state throws down unfunded mandates onto local municipalities, that takes away dollars that then could be used to fund lead abatement programs, right? Or early home visitation programs. So when budgets are happening, being able to go in with that mindset of, if we are having unfunded mandates or where other dollars that have the flexibility to be moved around are going, how will that impact behavioral health overall? I think is really something to keep that lens in mind of.
Thank you for that. Am I doing good on time? How much time I have left? I have 2 minutes. Okay, perfect. I was making sure we had time left for questions. Okay, I'm just trying to keep my facilitator things intact. And so I think you've given us a lot to think about, right? So we've talked about the impacts and grounding of public health and what does it look like. We have a better understanding of potential opportunities for investment. One of the things I just want to, again, connect back because we've gotten a lot of information around is as we think about making our budgets, what is the ROI, right? Like that on appropriations, when I'm talking to my colleagues, fighting about what I think we should allocate money to or take money away from, it becomes around priorities and the ROI. Is this the state's role? What does that look like? And so if you could maybe just from your point of view, again, in your area around public health, behavioral health, like what is that ROI? If we invest these dollars, here's the savings that we can see for taxpayers. And anyone feel free to start. I can't remember the order I was going in to mix it up.
You want?
Go ahead. Go ahead.
I can start. So let's talk about payment and delivery reform here in the state. That easy policy issues. So number one, there's only one known model that saves money and improves quality of care, right? And that's using health incentives. So to make sure that people stay healthy as opposed to a fee-for-service model. And if I can get my 45 seconds, my best.
You can have a little bit longer because we have like 2 minutes. So, because help me, like, what is a health incentive? Like, help us unpack this model because I think it's really helpful to hear a practical, right?
Okay,
like
so
what this looks like.
Perfect. So there's value-based healthcare or value-based models, and there's fee-for-service. Fee-for-service, you all know, right? You need a mammogram, you go pay for your mammogram. Value-based healthcare is very different. And the best example is from my brother-in-law. He has two kids in Texas, Fort Worth, and every year they have to make the pilgrimage to the mother-in-law. And guess what kids do in the back of a car for the long trip from Texas to Massachusetts? You know it all. Are we there then? He's hitting me, et cetera, et cetera. Nothing worked. And then he found the perfect system. He gave them both cups of quarters, right? And the moment they complained, he took quarters out of the cup. And the kids realized very quickly that if they just played their games, they'd have more quarters at the end of the trip to use. And that is value-based healthcare, right? So it's basically saying, I'm paying you to keep people healthy as opposed to fill my cup full of quarters, right? It's like, oh, I get to keep my quarters if I keep you healthy. Obviously, you have metrics around that to keep you healthy. It's the only one model that we know in America that leads to improved quality and decreased costs. And the legislature has an opportunity. They can incentivize value-based healthcare in this state and has some other states are doing. Again, it's not a novel idea. So that's one idea. The second idea is around primary care. So we know for every $1 you put into primary care, you save $13. So in Nebraska, primary care spend is probably about 4 to 6%, depend who you talk to. And we know that it should be around 12 to 15% spend. And some states are moving up through policy options, the amount of spending on primary care. But there you go, $1 in primary care, $13 in prevention that we could get. So here's two examples with policy options near them.
Thank you, Dr. Khan. And that is perfect because now we are ready for questions from the audience. So I hope y'all been thinking.
That's exactly what I was going to say. Yep.
Can everyone hear me okay with this microphone? Perfect. Okay, so...
But if people still have questions, they need to do this Mentimeter. Okay, so if you have questions, we are upgrading to our technology. Do the little Mentimeter so that we can make sure it gets asked. Okay, go ahead, Noah.
The first one is, what motivates you to remain engaged in this work when there's so much misunderstanding, dehumanization, defunding around public health? What keeps you engaged? Why do you keep going?
James, do you want to maybe start with that?
Yeah, one of the things that I've struggled with a lot is, communicating myself, right? Because, I'm not the world's most optimistic person, and I've been trying to figure out how to message that out to folks. But, if I'm being 100% honest, I'm really worried about the future, right? And I'm not going to say that I don't have no hope, but I do have a lot of fear. And it's because that I think that the future looks a little bleak. That almost empowers me even more to go down swinging, right? And to get as much education out there and to be able to do as much good as possible and to live in my own truth about policy and programs and funding that actually works, right? We don't have time to, I know diplomacy is a good thing, right? I don't want this to be the takeaway that I don't believe in diplomacy, but like, I just don't have time or the energy or the mental capacity to be lukewarm about decisions that are being made, especially when it's talking about people's lives and our society lives and also individuals. So the fact that I don't have a lot of hope for like the natural course of what may take place in the future is what's a call to action, at least for myself, to be able to not be lukewarm, to live in my truth, and to be strong in the decisions that we make.
Anyone else want to add to that?
I can add to that. I would say it's easy if let's just say a fiscal conservative mindset it's really easy to say, well, we should be saving our dollars here, but it's a lot harder to then meet somebody, your neighbor out in the community who you see, you learn their experience, you see that we have to move past this mindset that this is an individual problem. This is a political problem. And as soon as you learn the experiences and the actual tangible things that are happening, causing, unhoused individuals to be where they are in their life or having chronic disease, once you learn those experiences, it reframes your mindset a little bit more. So I think that's what keeps me motivated, is that I am on the ground. I am talking to people who may not know. And as soon as I can sit in front of them and kind of, provide that education, sometimes mindset shifts. And I'm hoping that similar to how the consumer dollar is very powerful, so is our voice, right? We just need to have that knowledge and education. I think that I'm speaking as a teacher. So that knowledge and education can create waves and movements. And this is one of those examples.
Next question, Noah.
So there's two that I think dovetail pretty cleanly here, and you've all addressed it to some extent or another. The first is, what are your thoughts on addressing agricultural and environmental impacts on the health of rural populations? That also dovetailing with the current state of healthcare workforce availability. I think that is certainly something that you've all kind of addressed as being a major part of how we can address those health outcomes. Could you talk a little bit about how some of those policies go together?
Yeah, maybe Dr. Khan, if you wanted to talk about, and I think maybe even uplift some of the models that you have seen as a university with some of that rural workforce building.
So as everybody in this room hopefully knows, we talk about health disparities all the time, and people's mind usually goes immediately to either gender health disparities or racial or ethnic health disparities. There's also urban-rural health disparities that people forget, right? So if you live in rural America, your health is worse than if you live in urban parts of America. Some of it has to do with the access issues. Obviously, you don't, 5 minutes away to your doctor, but some of it has to do with the conditions where you live, work, play, and kids go to school, right? And that make your health poorer. And there's a number of different models to try to address those issues that are both medical models. So we have systems here in this state, for example, to train rural practitioners. And the legislature was very generous of expanding medical workforce development in Kearney. So at UNK, I believe physicians will start training, I believe, in 2 years. Is that right, Senator? I think in about 2 years, we'll start training physicians out of Kearney. So in addition to existing rural health opportunity programs across the state, and then needs assessment and other work in rural parts of Nebraska to try to improve health within the state. So there's a lot of efforts, but not enough. And we do know there's a significant disparity that needs to be addressed.
Thank you.
Do you guys think that it is realistic to expect larger state investment in public health to be viewed as potential investors as increasing the likelihood that they should invest? Do you think that public health is something that businesses are looking at when they're considering bringing their operations to Nebraska?
You want to start with that?
Yeah, unless you guys.
Well, I just didn't want to put y'all on the spot to answer that. I can answer it too.
Go for it.
Okay. Well, I think I think that there needs to be, so the question, just to kind of reframe, was around, do businesses, and as we think about growing our economy and prioritizing public health, is that something that people look at, and what does that look like? And I would say yes. If you look at the data, and there's been lots of conversations over the years around how do you retain a workforce, how do you attract a workforce, and the difference that it makes when we grow our economy. There was a report that just came out from the Exarban Foundation around what our economy looks like compared to like cities that we're stagnant and we're not growing. And I think a lot of times people situate the conversation just on like tax credits and incentives, where for me, I'm a community organizer by heart. And so I say, like, what is my culture and the environment of the place that I'm moving to? And I do think that it has been a missed conversation in specifically for me, the state legislature, around the culture that we are building, and does that allow for people to see themselves in the state? So if we pass policy that specifically excludes a certain type of person, then no, that company is not going to come here, because those folks that we are excluding are a part of their workforce. They are our neighbors, our friends, our family members. And so people have choice. And I think the pandemic showed us that there are other work styles and models that people will go to. And those are the states that are growing and are able to attract and retain talent. And so outside of very tactical tax policy or economic development initiatives, we really need to ensure that we're building cultures and communities that uplift immigrant populations, that don't exclude queer folks, that we are addressing pay equity and racial gaps. Like, we need to make sure that there's arts and culture and people can see themselves here, that they can live, work, and play, and that it's not solely just on this very economic binary lens. Did you want to add?
I just want to say, I've been pleasantly surprised with how many corporations have started to reach out to NAMI chapters across the nation, Nebraska included, to talk about and to get advice on how they can become more employee friendly and how they can be aware of behavioral health challenges and how they can support their workforce. And so I think that really does show that businesses are really putting that more and more at the forefront of their mind. And I think it's really important to encourage that and to support that.
Yes.
So there's two pieces to this. The first is the data is pretty clear. People will move to communities that are healthy. There's no doubt about it. So that's a reason in itself to create healthy communities if you want thriving cities and states in Nebraska. But the second piece is almost 20% of every dollar spent in America is spent on healthcare. Employers know that, right? And if we have great strategies in the state around prevention and healthcare isn't as expensive for them, that's another reason for them to come to this state, is because healthcare isn't as expensive for them. And I guess I could extend that also to the Medicaid lens and the $3 billion. If we think more proactively about public health and prevention, you can actually shrink that spend by spending more money on prevention-related activities.
Thank you. So can y'all believe we're at time? I feel like that went really quick, and I really enjoyed this conversation. Did y'all enjoy the conversation? Okay, good. So as we wrap up, this is our tap lady coming to wrap us up, Lillian. So as we wrap up, if you each can just give one thought or piece of advice. We talked about a lot of things. There was a lot of great information given. If no one listened to anything that we said, and there's one thing that you want them to take away from this conversation around creating healthy, thriving communities, how we address that through our budget or our prioritization, what should we know? What should we leave people with? And maybe let's start at the reverse, Dr. Petersmith, and work our way back.
I would just encourage you to think about, to shift our lens that health shouldn't be transactional. So shift our lens to thinking about outcomes and bringing people together in the sense of community.
And I would say that there's a couple of well-defined policy options that we know work elsewhere, that if we implemented it here, we could save money and improve the quality of care of our Nebraskans.
I would say being authentic with your story and being willing to share your story is what will drive tangible change in our community.
Thank you. Let's give our panelists another round of applause.